When we eliminate opioids from our anesthetic, there are over 20 side effects that are eliminated or drastically reduced. When a provider actually takes the time to think about this, it is amazing that by eliminating just one class of medications, we can essentially change the patient's complete perioperative experience and possibly their life. An anesthetic that can provide the same degree of analgesia with minimal impacts on respiratory depression, airway compromise, postoperative nausea vomiting, pruritus, constipation, ileus, urinary retention, and immune suppression is certainly desirable. In addition, any method or technique that we have that can reduce the possibilities of hyperalgesia, addiction, and dependence are also very desirable. Just like we have the triad of analgesia, amnesia, and akinesia for anesthesia, in opioid-free anesthesia, we have the triad of intraoperative hemodynamic control, reduced postoperative pain control, and avoiding postoperative hypotension and sedation. First, we need to have intraoperative hemodynamic stability. There are plenty of studies demonstrating that we can do this with just esmolol or dexmedetomidine or even just ketamine. The problem is that if we use just a single agent for intraoperative hemodynamic control, we have a hard time accomplishing all three goals. We want to give an anesthetic that not only gives a smooth intraoperative course, but maximizes postoperative pain control and doesn't leave the patient excessively sedated. A brief overview of pain pathways and physiology is necessary to understand how the medications used in opioid-free anesthesia work. The vast majority of peripheral pain nerve fibers are called C nerve fibers. Under normal conditions, they are specific to the type of pain, either mechanical, thermal, chemical, or inflammatory. They are considered high-threshold nerves, meaning it takes a lot of stimulation to cause them to fire. The peripheral nerves synapse with the spinal nerve fibers and cause them to depolarize, and the pain signal propagates up the spinal thalamic tract to the thalamus and onto the areas of the brain responsible for pain perception. The primary neurotransmitter between the C nerve fibers and the spinal nerve fibers is glutamate. Glutamate binds to 11 different receptors on the spinal nerve, but the primary two are the AMPA receptor, which controls the sodium channel, and the NMDA receptor, which controls the calcium channel. Normally, the calcium channel contains a magnesium plug in it that limits the amount of calcium that can come through. Deeper in the terminal of the C nerve fibers is a second pain neurotransmitter called substance P. Substance P is only released during uncontrolled, prolonged pain. It binds to neurokinin 1 receptors on the spinal nerve fibers. And while it can't make the spinal nerve fiber fire all by itself, it magnifies the transmission of pain when glutamate is already present. At the same location, touch nerve fibers from the same dermatome also synapse. When the touch nerve fibers are activated, they activate a second nerve fiber called an interneuron that releases GABA and glycine, which function as inhibitory neurotransmitters, preventing the release of glutamate. When the pain signal reaches the thalamus, it is routed through the periaqueductal gray and the locus ceruleus, in addition to the parts of the brain responsible for conscious experience. The periaqueductal gray and locus ceruleus are responsible for limiting the amount of pain perceived, and they do this by releasing inhibitory neurotransmitters like endogenous opioids, serotonin, and norepinephrine. They also activate descending nerve pathways that, when activated, hyperpolarize the ascending tracts, reducing the pain signal being transmitted. When C peripheral pain nerve fibers are exposed to inflammatory mediators, they undergo a variety of changes. They lose their specificity to the type of stimulation. They go from high threshold to low threshold. They have a magnified response to the amount of stimulation, and they continue firing after stimulation is stopped. Central sensitization occurs when peripherally sensitized C nerve fibers transmit excess glutamate into the synaptic cleft with the spinal nerve fibers. The body builds excess AMPA receptors for the glutamate to bind to, and the magnesium plug blocking the calcium channel is lost. This leads to magnified transmission of pain from the spinal nerve fibers. The excess glutamate also causes the death of the interneuron, which is defined as allodynia. Not only is the inhibitory effects of the touch nerve fibers lost, but it also causes touch to be perceived as painful. One of the goals of opioid-free anesthesia is to use medications intraoperatively that blocks these processes through the use of anti-inflammatories, NMDA receptor antagonists, and activation of the inhibitory pathways, as opposed to opioids, which actually magnify this process. Alpha-2 agonists are clonidine and dexmedetomidine. Clonidine is an older medication that isn't as specific for the pain and sedation receptor subtypes as dexmedetomidine. In addition to providing analgesia and sedation with very little respiratory depression, their secondary effects are also very beneficial, including anxiolysis, reduced postoperative shivering, and reducing emergence delirium, especially in pediatrics and the elderly. Their mechanism of action involves inhibiting release of substance P and activating the descending inhibitory pathways from the locus coeruleus. Because clonidine is not as specific for the pain receptor subtypes, its analgesia is seemingly not as dense as that of dexmedetomidine. However, it has a 12-hour half-life, which can be a double-edged sword. The beneficial effects of clonidine can last for a long time after surgery, but if the patient gets too much, they will be sedated and hypotensive for a long time. In the literature, you see dosing of anywhere between 2 to 5 mics per kilogram. Personally, one way I have found to make sure that I'm not giving too much is to draw up my maximum dose, give 100 micrograms of that on induction, and then 50 micrograms PRN for hypertension or tachycardia, and to never give more than I initially drew up. There is literature out there examining clonidine infusions during surgery, but given its long half-life, that is not something I personally encourage, unless you are doing an extremely long surgery. It can also be given PO, which is very cost-effective, but absorption has a wide range of variability and you lose the ability to titrate your dose. Dexmedetomidine is the newer alpha-2 agonist approved to treat humans. In veterinary medicine, there are 5 different alpha-2 agonists and they have a reversal agent available. Thankfully, dexmedetomidine has recently become generic and is extremely affordable now. When giving the loading dose of dexmedetomidine, it has to be loaded slowly between 5 to 10 minutes or there will be paradoxical hypertension. In addition to that, it takes dexmedetomidine 10 minutes to reach its peak effect, which means between its slow onset and the need to load it slowly, The loading dose has to be initiated as early as possible to achieve effect during induction and intubation. After the initial loading dose is in, an infusion can be initiated for shorter cases, or PRN boluses can be given. Just like the alpha-2 agonists, NMDA antagonists have very beneficial secondary effects in addition to their ability to provide analgesia and sedation. These effects include bronchodilation, antidepressant effects, anti-inflammatory effects, and reduction in postoperative shivering. While we do want to avoid side effects, there is a prevalent belief that just because you give ketamine, you have to give a benzodiazepine like midazolam with it. This belief stems from the days when ketamine was more commonly used as an induction agent with much higher dosages. And if you didn't give a benzo with it, they would hallucinate for a long period of time and the PACU nurses would be very upset with you. With the much smaller doses used in opioid-free anesthesia, it's not necessary to give a benzodiazepine prophylactically to prevent hallucinations. But if you do give a little bit too much or give it a little too close to the end of the surgery, you can use the benzodiazepine as a rescue as necessary. Every study about magnesium mentions that it prolongs the effects of non-depolarizing paralytics. However, that doesn't seem to be clinically relevant given the variability in duration that already exists with current paralytics. Ketamine blocks the glutamate receptor on the NMDA receptor. Magnesium prevents loss of the magnesium plug in the calcium channel that the NMDA receptor controls. To avoid hallucinations from ketamine in the recovery room, try to avoid a bolus and/or turn off the infusion 30 to 60 minutes prior to emergence. Most of the literature on magnesium shows that the majority of the benefit comes from the induction dose, and there is very little benefit to the maintenance infusion unless the case is extremely long. The induction dose should be infused slowly over 30 to 60 minutes. Sodium channel blockers are our third class of medications. In addition to the analgesia they provide, they are a potent anti-inflammatory, suppress coughing, and are antiviral, bacterial, and fungal. While the dosing is very safe and gives a wide margin of error, use caution in running lidocaine infusions on patients who are susceptible to seizures. Lidocaine blocks sodium channels, preventing both peripheral pain nerve fibers and spinal nerve fibers from depolarizing. Premixed bags of 0.4% lidocaine exist, but oftentimes they are not available in the operating room, and if there isn't a smart pump with that concentration of lidocaine already in it, it takes time to work out the math. An easier solution is to use 2% lidocaine in a syringe pump, both of which are more commonly available in operating rooms. The math works out to 0.1 to 0.15 milliliters per kilogram per hour. For example, an 80 kilogram patient would get 8 to 12 milliliters an hour. Out of all the beta blockers studied to reduce opioid use in anesthesia, esmolol is the most widely studied because its short duration of action means that it is extremely safe and can be used in surgeries that have intermittent periods of high stimulation. There is an academic debate about using beta blockers in anesthesia based on the fact that their use decreases pain and opioid use for 24 hours after surgery, long after they are metabolized and excreted. The question is whether or not this effect is simply due to preventing opioid-induced hyperalgesia and tolerance, or if they are also preventing surgical hyperalgesia in some way. While we don't have a direct answer to this question yet, we do know that the autonomic nervous system is tied to chronic pain in some way. We know this through the effectiveness of sympathetic nerve blocks being used to treat chronic pain, and we know that there are patients with certain genetic disorders that have dysfunctional beta receptors and also all suffer from chronic pain. So while we don't know the mechanism yet, it does appear like using beta blockers affects pain. Studies on esmolol fall into three groups. Group 1 is the amount of esmolol needed to blunt the hemodynamic response to intubation with no other adjuvants. Group 2 involves running an infusion at a set rate with the goal to reduce opioid requirements. Group 3 is the dose necessary to control intraoperative hemodynamics with no other co-analgesics administered. As you can see, there is a wide range of dosages reported. However, the takeaway is that esmolol is a very safe option with a large therapeutic window. Deciding how to administer an opioid-free anesthetic depends on several variables. If the case is less than 2 hours, it can be more time efficient to just use PRN boluses as opposed to running infusions. For longer cases, it is definitely more efficient to set up infusions. There aren't any studies yet to compare the effectiveness of bolus versus infusion techniques. If running infusions, there is literature suggesting mixing medications in a single bag or syringe is a valid method of administration. It can be used when multiple pumps are not available or to increase time efficiency. However, the ability to titrate each medication individually is lost. So for cases that are more complex and may need a higher level of precision, multiple IV pumps are preferred. This is what a standard opioid-free anesthetic looks like based on the most commonly used protocols in the literature. Remember that it is necessary to start titrating in the dexmedetomidine early as the patient leaves pre-op or as soon as they come through the doors of the operating room. When combining dexmedetomidine, ketamine, and lidocaine, it is not often that esmolol is needed as well. However, it can be used in the instance that despite the doses of dexmedetomidine, ketamine, and lidocaine, the heart rate or blood pressure go up on intubation or incision. Another time it may be useful is for extremely short cases that need to be intubated. In that instance, it may be desirable to reduce the dose of dexmedetomidine and ketamine to prevent postoperative sedation, and instead add some esmolol. The magnesium bolus can either be run on a pump or added to the first bag of IV fluids, depending on how much control over its rate is necessary and the availability of IV pumps. This is an example of using bolus dosing during the maintenance phase of the surgery. This may be the choice either because the case is short and it isn't time efficient to set up an infusion, or it may be a situation where IV pumps are not available. Even when primarily using boluses, many will still put the lidocaine on a pump. However, if no pumps are available, it can be left out, or the hourly dose can be calculated and given as a bolus each hour. Dexmedetomidine and ketamine are given as boluses PRN for hypertension or tachycardia during the case, and generally both are given at the same time. The goal is to not give any within the last 30 to 60 minutes of the case, and esmolol can be given instead during this time period, or any time period where the provider feels like the patient has already received an amount of dexmedetomidine and ketamine that may make post-op sedation possible. The one caveat to this rule is that if the patient hasn't had any dexmedetomidine or ketamine within the last 2 to 3 hours prior to emergence, it is beneficial to give a small bolus of them during wake-up to help reduce postoperative pain. If the case is going to be longer and the decision is made to run infusions, these are the dosage rates. The 3 major medications are dexmedetomidine, ketamine, and lidocaine. Magnesium can be added as well, but unless the case is significantly long, there is not a lot of evidence to suggest an infusion has much benefit after the loading dose. Esmolol is not commonly infused as part of the standard technique, but given PRN, either infusion or bolus, at induction, for stimulating parts of the case, or at the end when the drips have been turned off. Again, to reiterate, it's good to turn the infusions off 30 to 60 minutes before emergence to avoid postoperative sedation. If there is only one IV pump available, or if it is just more time efficient to just use one, there are multiple published approaches to mixing the medications into one bag, but this is the one that I find the easiest to mix and calculate dosage rates. It involves mixing 2 mics per milliliter of dexmedetomidine, 1 milligram per milliliter of ketamine, and if desired, 10 milligrams per milliliter of magnesium and 2% lidocaine, and running it at the same rate as if you were just running a lidocaine infusion. Esmolol is usually given as a PRN bolus and not added to the infusion in this scenario. When you do a new anesthetic technique, there are differences that you should be aware of. With opioid-free anesthesia, it often takes the patient an additional 5 to 10 minutes to go from anesthetized to awake, which requires relearning when to start emergence. But with practice, it is possible to not delay emergence. One thing of note is that the patients often go from anesthetized to completely alert very quickly. In opioid-free anesthesia, we don't give any medications that slow respirations. It is normal to see the patient breathing 30 times a minute at the end of the case when they resume spontaneous respirations. This is a normal effect of the anesthetic gases that is normally suppressed during an opioid-based anesthetic. It does not need to be treated and will slow down as the patient wakes up. It makes a lot of anesthesia providers nervous, however, the first few times they see it, as under an opioid-based anesthetic, it can be seen as a sign of inadequate analgesia. Patients will have far less nausea with an opioid-free anesthetic, and it's possible to reduce the number of antiemetics given. Patients have less pain and require less opioids to treat that pain with an opioid-free anesthetic.